I want to welcome you now to the Roundtable discussion. I'm Caroline Hyde from Bloomberg Television, sat alongside some remarkable doctors who have been forging the process of understanding anxiety, in particular within children. We welcome everyone, both virtually and in real life, so thank you very much indeed for being here. And I start the conversation with a pretty basic form of data collection, but probably one that needs to be addressed to a certain extent. And I asked Rochelle first and foremost, can you just, from the years that you have been diagnosing and ultimately understanding and putting a name to anxiety and ADHD, has the numbers increased, or are we just better at diagnosing it?
That's a good question. Frankly, I think it's pretty stable. It's very hard to be for sure, but I think that the epidemiological studies are fairly consistent over time, that the anxiety disorders are the most common among children, and they vary as a function of what's going on in the world, maybe, but otherwise, I would say, Danny may correct me, about 10% of the population?
Yeah, I mean, there are a couple things I would say about this. One is it's hard to get a real clear answer because there's so many different ways to measure it. The second thing, like Rochelle was saying, they are the most common. And the third thing to say, there is a clear trend that the rates have been increasing for at least 5 years. By how much is not clear, but again, as Rochelle said, when things are more stressful in the world, definitely related to the pandemic, we did see an increase in terms of what kids were reporting.
Chad, to that point, is there anything in everyday life for those of us lucky enough to live into the developed world where, yes, we all had the upending moment of COVID and being locked down, but on our everyday lives, is it more about technology that is impacting us, or is there modern day life stresses, other than, of course, in developing nations and those that are inflicted by war?
Yeah, that's a great question. And there are so many things that are different now about our society than were present 10 or 20 years ago. And so it's tempting to link some of the changes in anxiety to those. Certainly, the increase in social media is a question that use is a question that a lot of people have. Also, the way we raise our children is different than before. So I think, well, this is just an idea, but there's overall, I think, less independence for children. They're more observed and curated. And one of the important things for children with anxiety disorders is to become independent and to feel comfortable separating from their parents, exploring new things. And so I think it's very important for parents to continue to encourage independence in their children. It seems to be a shift a little bit in the way that the childhood experience.
I'd like to bring it out to Barbara Rothbaum now, who, of course, is someone very much focused on the world of technology as a way to treat anxiety and ADHD. But do you feel that in some ways it is the environment in which we're bringing up children that is perhaps driving up the cases of anxiety?
First, I just want to congratulate Dr. Klein and say what an honor it is to share this virtual stage with her and with all of you. Yeah, I think like everything, it's a blessing and a curse. So, for example, with virtual reality, my favorite of the virtual reality applications is the virtual airplane, because it works just as well, and we don't have to actually fly with patients. We can take off and land as many times as we want, all without leaving my office in my 45-minute therapy hour. So when you're using technology like that, it can be helpful. You know, even, I mean, there are a lot of apps on our phones that can be really therapeutic and helpful. Flip side is we see the kids who won't leave their phones, and then y'all mentioned cyberbullying. Well, you didn't really mention cyberbullying, but the social aspect and the bullying, it's terrible, you know, and it's ever present. So like Chad was saying earlier, how we parent has changed, how kids live in the world has changed, and they live in this world with their phones.
Shan, from your perspective, your work with Harvard, is it similar to what's being echoed right now? The data is moving up and to the right in terms of the number of anxious children, and ultimately the catalysts you're hearing identified, they're ones you agree with?
I think I agree with the general sentiment that it's hard to know exactly what the catalyst is. We don't have methods that definitively answer some of these questions, but we are seeing a lot more anxiety, and we're working hard to come up with better treatments. It's whether it's how much of it is driven by upbringing, how much of it is driven by improvements in diagnosis. I think, as Danny mentioned, is a very difficult question to answer.
Yeah, Danny, can we just go back to a moment where you said it's hard to ultimately understand what the data is and to measure it? What data do you look to at the moment?
Yeah, well, so the best kind of research that we can do is research that uses very detailed clinical measures. And as Rochelle mentioned in her comments, this is getting increasingly difficult to do, partly because it's expensive. The other thing to say is one of the things that we're learning, and I think this applies to social media and stress and many of the other things we're talking about, it's rarely the case for common mental disorders, and most of the things that we're discussing, ADHD, anxiety, are common. It's rarely the case that it's one big thing that does it. It's usually complex mixes of things that all work together. And it makes it very hard to pick one thing and say, this is really the culprit here, because it's rarely the case that it's one thing.
So Rochelle, when first identifying the numerous amounts of people who in some way had a form of anxiety and ADHD, the first treatments you began, the most popular ones that you wanted to gravitate towards, can you articulate them and ultimately discern whether they're still relevant today?
Well, what we chose to do, and it turned out to be extremely successful, is to instill some sort of stoicism, in the children, and to enable them to experience the things they were afraid of or anxious about. And through experience, they learned that this was not necessarily dangerous or fearful. And that's the approach we took, and it's survived to this day. It's the most effective way of treating anxiety so far.
So exposure in many ways. I'll let you take a sip of water, but I want to sort of drill down on, we were hearing how now it's about flight. And maybe nowadays, many of us are getting into aeroplanes and are more aware of some of the anxieties that brings. But when you first started your work, what were some of the most popular areas with which children found an anxious moment?
I'm glad you raised that, because we talk about anxiety in general, and I think that's a mistake. There are different forms of anxiety, and they originate from different sources. We started working on the basis of Don Klein's work with children with separation anxiety, but they're very different from children who have performance anxiety. Right now, there's tremendous pressure in many classes for children to perform in school. This was less true years ago. And as a result, they developed some form of anxiety, which is very different from the separation anxiety. And where that one comes from is an unknown question, really. We can't really answer it. Why do some children develop separation anxiety and others don't? I don't know if Danny would agree.
Yeah, no, I think you make a wonderful point about how anxiety is not all the same. Then
Exactly.
Social anxiety is another really good example. It's a very different thing. And, the other point that you made that actually both you and Chad were making, that there is kind of a balance that parents and society has to walk. On the one hand, you're absolutely right that we need to expose everybody, kids, parents who are anxious, to the things that they're afraid of. On the other hand, we have to do it in a way where it's constructive and where they can master it. And that's really where clinician expertise come in, because it's not a one-size-fits-all that you know exactly how hard to push just based on a cookbook.
Chad, has there ever been seen some sort of pattern or formula that those who've had separation anxiety have got some similarities in the way that they've been parented? Or indeed parents who, for example, a fear of heights is inherited sometimes rather than actually factual. Is it well, that was my own personal experience with my mother, but whether or not you find that people who have certain fears are because of the way that they're parented and they experience the anxiety that the parents have felt?
Yeah, that's a great question. And we know that anxiety disorders run in families. And it's probably, or it is both a combination of genetics, so you're born with the same genes as your parents, and also the environment, what happens to you. And one of the largest environmental impacts are your parents and how they interact. And there are parenting behaviors, and I learned this from these guys, that can reduce a child's risk for continuing to have problems with anxiety if they're showing early symptoms. And those things are doing things like being supportive and empathic, so helping your child understand what they're going through and what the emotion is, but also being in control, and as Danny says, gently and adaptively encouraging independence and gradually facing what that fear is, as opposed to other extremes of parenting, which could be being sort of more authoritarian, where you might tell your kid to do something, but you're very cold and not empathic, or being more of what we call kind of passive parenting, where you might be empathic, but you don't encourage so much your child's independence. And so I don't think we think that parents ultimately determine if a child has anxiety or not, a disorder, but you can probably maybe nudge your kid a little bit one way or another. So it's an important consideration.
One would have thought, Barbara Rothbaum, that parents who come to you are inherently empathetic or at least supportive of the situation their children are going through and trying to address it in some way. Have you ever read across the room of understanding when children are coming to you for some, say, for example, you referenced flying, have the parents have experienced that as well, and how have you managed to ultimately tackle that when everyone's in a room together?
So just to clarify, I work with adults. And I think that what everybody has been talking about here, basically therapeutic exposure. So I tell my patients, I tell my own kids, you can be anxious and do it anyway. And then helping them to understand how to do it, to make it a therapeutic exposure, to learn something, to learn up here that whatever I'm scared of doesn't really represent that level of threat that it feels like it does, to learn in here, in their bodies, that they can stay with it and the anxiety will come down. And as everyone's been talking about, there are different methods for doing that. And there's probably a sweet spot because you want people anxious. You want them engaged, but not so much so that they're no longer learning. And so figuring out that I tell my patients, you're going to have my fingerprints on your back a little bit, and I'll push you out of your comfort zone, but not out of your safety zone.
That's a good way of articulating it. You were responding to that.
I think it's a very good point. I appreciate you making it. It's exactly right. You don't want to be cruel about it. You want to be constructive.
Dr. Shan, when you're thinking about the work that you're doing when it is in stimulation therapies, at what point down the road of anxiety and diagnosis and treatment are they coming to you for perhaps what is deemed in some ways a more novel treatment?
Yeah, it varies quite a bit, and it depends a lot on somebody's very personal preferences. There are a lot of people who come to us very early saying, you know what, I want to try the new things, the cutting edge technology, because I don't want to deal with all these conventional things that my parents went through or that all of my friends have gone through. I don't like those medications, those psychotherapies, etc. Other people come to us after having tried all the conventional treatments, going through years or decades, 20 or 30 medications or psychotherapies, and have failed everything. Those are often some of the most satisfying patients to treat, because when we get them better, they come back afterwards with a sense of, why didn't somebody offer this to me sooner? Sometimes they get angry with us. So why didn't your field know about this sooner? But it runs the gamut. But I think it's getting to be used more and more earlier in the treatment course.
So Dr. Siddiqi leaps us forward to more novel treatments, but Rochelle, I bring us back to, maybe the gamut of what you were running in the first points of treatment. What are some of the areas that you first take a child or indeed young adult through to be able to ensure, whether it's exposure, but then what? At what point do drugs and medicines start to become articulated?
Well, first, what's striking is that children don't report that they feel anxious, although they actually hide it. Why? Because they know that it doesn't make sense. They see their brothers, their sisters, their peers do the things they're reluctant to do, and they hide it, and they make excuses. The parents buy that, and they don't understand that the child is anxious. And the first step is to educate the parents, to help them recognize that this is something that the child experiences, just by doing that, I've experienced in my work that there's great relief in the family.
Acknowledging.
Acknowledging,
ultimately.
yes.
What are the ways in which you found are the best ways to acknowledge? If the child is very good at hiding that they don't like to perform, but it's that moment they needed the bathroom or whatever way they managed to move or obfuscate, how did you help parents peel away or educators peel away the idea that this is a theme?
Well, this is really common sense. The approach I use is that I ask the parents what they make of this. I let them express what their thoughts are. And then I make suggestions for them to consider. And usually that works. I don't know about your experience, Danny, but that's what I've observed, that it's a revelation in a way and a great relief sometimes. Sometimes it's not. It's sort of a sorrow that your child is anxious. They would prefer the child to be afraid of horses or cars or whatever. But at the same time, I think it helps them be courageous about helping the child deal with it.
To that point, have you found methods in which you're able to articulate, when have been the moments that have been most hard to clarify that there is actually something that a child is hiding?
Well, again, I think both Rochelle and Chad have made this point that it's hard. It's hard to raise kids, even in the best of circumstances. And I think parents really are relieved when they hear that you've seen this before. It might look really strange and it might not make any sense, but exactly as Rochelle said, these are some of the explanations that I've seen in the past. And what you'll find more times than not is something will strike somebody as familiar, either the kid or the parent, and somebody will say, yeah, that's me. And then when there's this sense that this is something that we've seen before and we know what to do with it, and we can be hopeful because compared to a lot of mental health problems, pediatric anxiety is one of these things that has a really good outcome. And families are often very encouraged about that. Another really good point you made when you were talking with Rochelle, and I'll be interested to hear Rochelle's point on this. Both Chad and I are psychiatrists, Rochelle's a psychologist. In terms of when to think about medicine, I would say I do think medicines are also really excellent for many kids with anxiety, particularly in kids who have not responded to cognitive behavioral therapy. I think a big question is how soon to think about medications and how much to push. And Rochelle and I have talked about this for many years, so I'd be really interested in your thoughts.
Well, I think, Danny, you know what I feel about this. When it comes to, for example, ADHD, I'm a firm believer that the first step is medication, that you're actually doing the person a disservice by offering other interventions. When it comes to anxiety, I don't think that's true, because I've seen remarkable outcomes with children with whom you really made an effort to educate them and to help them cope. And to that extent, I think medication comes in when that's too difficult. And there are children who very much improve with behavioral interventions, but who retain a basic anxious style. And in that sense, even though they behave normally, they're not comfortable. I think you should use medication.
So I think it's really important to point out, Rochelle is a psychologist, I'm a psychiatrist. I completely agree with her, both in terms of for ADHD, children who are impaired need to have medication, and with anxiety, even though, again, I'm a psychiatrist, starting with CBT really makes sense. So,
I would correct that. I think starting with BT.
Okay, behavioral therapy.
Right.
Let's just go through the nuance of that.
Yeah.
What does a behavioral therapy look like, and what's the next step to a cognitive?
Barbara's smiling. This is an old fight in psychology, so I don't know that there really is such a thing as BT without C. You're always doing some of it, but I'd be interested in what Barbara and Rochelle would say about that.
Yeah, for example, let's talk about OCD, obsessive compulsive disorder. The treatment for that, exposure and response prevention, most people think of as a very behavioral treatment, and it is, and it's very effective. But we're also talking to the patients while we're doing the exposure. If they're touching something and they're worried they're going to get contaminated, I'm asking them, okay, what will happen to you and when? Okay, so if you're going to get sick, you're going to be sick by this time tomorrow. Okay, if you're going to be dead, if you're going to die, you'll be dead by tomorrow. Will somebody cancel your appointment? So that's the other thing. If you can use a little humor, it helps to help people have a bit of perspective. There are some more cognitive interventions like cognitive restructuring. There's some more behavioral things like exposure. And then most everything else, I think, is on a continuum.
But most people, I mean, Barbara and Rochelle can both comment on this. I think most people think that the behavioral component for all anxiety, particularly in kids, it's indispensable. And I think that was the point that Rochelle was making, that you really need the behavioral component. Is that fair to say?
I think it's essential.
Yeah.
Yeah.
Well, it's demonstrated. I mean, this is not just an opinion. When you look at the improvement curve with cognitive behavior therapy, it doesn't change until you introduce the exposure. I'm not saying you don't talk to people. I'm not saying you don't speak with them, you don't affect their thinking. But you have to support them, you have to share some understanding with them. But the fact that and that's what enables them to expose themselves. It's not just that you throw them to the wolves, you help them do that. But it's different from thinking that you're correcting their thought processes, and that's what improves their anxiety.
Yeah.
So just to agree with what you're saying, a couple other points about that is, one, in my experience, many kids have a hard time labeling their experience as anxiety. And so to do the work of the cognitive part can take a long time and can depend on them sort of learning what they're going through, which is a longer process. The other thing is, I think we all would, agree that it's important to start young when these problems are first starting. Even in 2- and 3-year-olds, you'll see reluctant to go into, for example, daycare or to socialize with other kids.
At what point is that the tipping point, that it's not just something natural in a first experience? At what point you're like, okay, this is happening for 6 months, a year? It must be hard to have a method to articulate that.
So, but just to say that the behavioral part is really important, especially for younger children. I think sometimes people ask, like, when is this an anxiety disorder versus sort of a typical level of anxiety? And the simple answer is that if it causes the child a problem, right? If they're not able to do something they're supposed to do, they can't go to school, they can't do what's expected of somebody their age. And of course it's normal to have a little bit of the first few days of school to be a little bit uncomfortable, but if it persists and it gets in the child's way, then we would consider it to be a problem. But ultimately, especially for something like the principles of behavioral therapy, it doesn't really matter if you call it an anxiety disorder or sort of typical behavior. As long as you're helping your child grow and learn how to deal with those experiences, I don't think it's that important whether or not they've crossed a particular line.
But I suppose the line, it's important because you then, if you've crossed the line, seek the help of the more novel ways that might find, or indeed medicine as well. I mean, I'd love to know from Rochelle at what point you've decided that definitely ADHD is something that is here and clear and present and must be medicalized initially.
Well, what I think is terribly important is whether the difficulties or the symptoms affect the child's and the family life in a variety of ways, not just in minor ways, and whether they can't really function in a way that's expected for their ability and their age. I rely heavily on the child's comportment during school. Why? Because teachers have a normative view of what childhood behavior should be, whereas parents are understandably and rightly so biased, and they make excuses for the child's difficulties. But if a child can't function in an ordinary environment, such as school, then we're dealing with something serious. Also, whether it's chronic, whether it's phasic, whether it's passing. If it's a sustained difficulty, we have to pay attention. And there, the history of the child is critical. When did it begin? If it's very recent, then you have to watch it and wonder. But if it's been there for a while, for a long time, then you know that you're dealing with a chronic, stable difficulty, and you have to address it. It's not fair to the child to allow him to continue, because as a result, he experiences a lot of negative behavior towards him. He gets hit on the head a lot, and that's not pleasant.
And Rochelle, by a while, you mean months or you mean a year?
I mean years.
Yeah.
So the other, just to add on to that, for ADHD medicines, stimulants are extremely effective, and they help the core symptoms of problems with focus and hyperactivity and distractibility. Unfortunately, the behavioral treatments for ADHD don't really help very much with those core symptoms. They may help with some of the problems that a kid with ADHD has, like they might not get in trouble as much, or you might be able to like adapt things to help them a little bit, like give them schedules or something, but it doesn't really treat their core symptoms in the way that a stimulant does, which is very different from anxiety, where the studies, at least most of the studies, suggest that medicines and therapy are about equally effective, and the combination is better than either one alone, in which case it makes sense to start with therapy for most kids. The other thing to add to this is that we've been talking a lot about anxiety disorders, just anxiety, but it's common to have both anxiety and ADHD. And there are a lot of unique challenges in terms of how do you help a child that has both anxiety and ADHD, and also what's causing the impairment. Is it the anxiety? Is it the ADHD? And I think in those cases, that's where it's really important to seek out professional help, a psychologist, a psychiatrist, a pediatrician, to help disentangle some of that stuff and figure out what's going to be the right way to start.
Dr. Siddiqi, what's interesting is you said at times people are approaching you and wanting to jump past some of the treatments that others have experienced, for example, medicines. But to your point, do you see are they coming to you largely for anxiety disorders? Is it ADHD? And at what point are you starting to see that you think the time frame is right to be pursuing your more novel treatment?
Yeah, it's a very important question that we have to ask on a routine basis. I have to agree with everything that everybody's said so far, that first off, in ADHD, the medications work best. The behavioral therapies don't work that well, cognitive therapies don't work that well, and brain stimulation therapies don't work that well either. If somebody wants treatment for ADHD, we advise them to take the medicine if they can. On the other hand, if somebody comes in for anxiety, many of these things are effective. Like Chad said, medications and psychotherapy are equally effective. Brain stimulation is so new that we don't know exactly how it stacks up in comparison. And so when a patient comes in and asks me for my advice, which of these things should I do first, I almost always say psychotherapy, CBT with a capital B, like as Rochelle mentioned, that one of the most frustrating things for me as a psychiatrist is when a patient is getting psychotherapy, but there's really no behavioral component to it with anxiety. And then of course medications, if that doesn't work, and then we still recommend brain stimulation when the traditional treatments aren't working that well. That said, I also respect patient autonomy and the parents' autonomy a lot. So if a person comes in and says, nope, this is what I want and I have my reasons, we'll make sure they understand why they're making the decision, but we'll give them the opportunity to get what they're asking for.
And to that point, when we're saying when it's a difference, we will come to you in just a moment, but Dr. Siddiqi, when do you have a difference when they have both? We were just saying the difficulty is to disentangle when they have ADHD and anxiety. When is it that you understand what the medicine is helping with one, and then you can treat the anxiety with the scans?
Yeah, and so I'm a neuropsychiatrist, so I specialize in cognition, and so I have a lot of people come to me saying, I have attention issues. Can you give me a stimulant for ADHD? And probably half the time, I think the underlying problem is anxiety. And the nice thing is that the anxiety treatments make attention better, but the ADHD treatments don't make anxiety better. They might even make it worse sometimes. And so this is a conversation that we have, and if a person comes in who has both, almost always we'll focus on treating the anxiety first.
Barbara, you were wanting to jump in there.
I want to maybe change directions a little bit, but we're talking about medications. I want to ask, because we've been doing some research. I specialize mainly in PTSD, anxiety and PTSD, and we've been doing some research with MDMA, with the psychedelics, and combining it with evidence-based treatments, and thinking in terms of most of our psychiatric medications are meant to suppress symptoms, whereas the psychedelics are not meant to suppress symptoms. They're meant to help people generally emotionally process what's going on. And so I'm curious, because I work with adults, and as you guys were talking about, you want to treat kids as early as you catch them, and you've got this developing brain. So I hope it's not too provocative. What do you think about using psychedelics in the developing brain?
Rochelle, take that first.
I don't have any opinion for or against. It's all up to what we know. And if it's shown to be safe in adults, I don't see why it shouldn't be tried in children. But first, we'd need very clear evidence in adults. And we talk about anxiety, but there are different anxiety disorders, and we can't assume that one intervention will affect all of them. And I think it's important to discriminate across conditions, not to throw everything in the same basket. Now, psychedelics might be helpful for some forms of anxiety and not others. And that remains to be seen. I have no principled objection to it.
Barbara, can you articulate a little bit about where you are in terms of the data that you're finding and how you're managing to build up both of you, Dr. Siddiqi and Barbara, are both working with novel treatments where the data isn't as rich and as long-term as it is perhaps with CBT, but how are you starting to build up that data trove to be able to present that it's really worked within adults, Barbara?
Yeah, so we've been doing research with MDMA for about 10 years. We've been doing translational research, so starting with animals. And in an animal model, we found that MDMA facilitated the extinction of fear, which is a good thing. We also found in that study that SSRIs block the MDMA effect. So that's kind of lousy because, as you were talking, many of our patients come to us on SSRIs, but it's important to know. And then we've done a healthy human study that was pretty much the same paradigm. And now we're combining it with prolonged exposure therapy in a masked format. So every day for 2 weeks and only using one dose of MDMA, which is different than how it was used in the phase 3 clinical trials. And I'm very excited about it for lots of reasons. One, kind of what we've been talking about, there's some data that the psychedelics and MDMA in particular makes the brain more plastic and makes it open to new learning, to new experiences. And an animal study that came out last year indicated for MDMA that there was probably a 2-week window, a critical period that was reopening. So by then giving them exposure therapy every day for 2 weeks, we think we're really capitalizing on that plasticity. We're early on. We've treated 5 patients, so I can't say too much. It's an open clinical trial to try to figure out the protocol because no one's done this before. But so far, it's been amazing. And the thing that has me so excited is that how easy it's been to combine MDMA with an evidence-based treatment. That's what people doubted, and it has been very easy to combine them. So it gives me hope that people will be able to combine them with other evidence-based treatments.
Danny, you want to jump in?
Yeah, I don't want to throw cold water on all of this, but I do want to point out a couple things, particularly about thinking about kids and anxiety. The first thing is probably both what I see and also from data that we have, the biggest contributor to failed treatment response is failure to have access to appropriate treatments. So I think before we should really prioritize things like either MDMA or brain stimulation, particularly if we want to reduce overall rates of anxiety disorders among kids in the nation, let alone the world, getting better access to the treatments we already have should be the priority number one. That's number one. Number two, I think we need to distinguish between kids who are suffering and haven't really had a good go of treatment, and that's a very, very large group of kids, and those are not the kids that we should be talking about experimental therapeutics for, and the kids who have had good treatment and have failed those. I think all the points that Barbara and I'm sure Shan and Rochelle were making, as long as we're talking about these are for kids who have suffered considerably for a while and have gotten good treatment and not responded, then I'm okay. But I get a little nervous when we start talking about that without acknowledging the failure really of the field and the healthcare system to do a better job of getting the right treatments in the hands of the kids who really need them. And I think we need to start with that point.
Shan, do you want to respond to that?
I agree completely. I think, like I said earlier, the majority of the time when people are coming and asking me for my opinion on this, I'll say start with CBT. There's medications that work really well. And if those things don't work, then we have stimulation therapies that are available. Some people prefer to skip those things. Like I said, that's their autonomy. But to answer your question of how we develop these tools and how we think about it, it's the goal has been to come up with a principled model for developing these things. Now, I'm a WashU trained psychiatrist like Chad, means that we learned Rochelle's approach of categorizing and defining illnesses and saying, here's what a specific disorder is. So when I started applying for NIMH funding and at Danny's employer, and they told me that's not how you think about things anymore. We're going to think about things in a translational sort of circuit-driven way. I was begrudging about it. I said, no, I don't want to do that, but fine, I'll play the game. But it turns out that brought us a lot of insights, and it kind of worked. So what we did was we sort of rebooted, said, how do we find map specific circuits that we want to modulate? We map those circuits, then we do clinical trials to try to actually see if we can successfully modulate those circuits. Our first few clinical trials for anxiety have been successful. Sorry, our first one. And then we go back to NIMH and say, could you please give us some money to do a larger clinical trial? And I'll get the answer to that question in a couple of weeks. But Danny, if you have any input on it.
Well, so to just clarify, I'm in the intramural program. So number one, I don't have anything to do with it. And I don't always agree with a lot of things that my bosses say.
But this actually starts to immediately bring about the funding question and ultimately access. Danny, you bring up a great point that you need to feel as though you've gone through all the accessible treatments before you take the next steps. And Chad, I know this is something you feel passionately about, that ultimately this goes back to very early treatment, but also access in many ways that we just don't have across our healthcare systems.
Yes, that's exactly right. And so to riff off of Danny's point, that making sure that if we really want to prevent and treat anxiety disorders at scale, it would be helpful to implement the stuff that we already know works, such as behavioral therapy. Another enormous risk factor for all psychiatric problems, including anxiety disorders, are social determinants of health, so socioeconomic status, et cetera. We know that kids that live in safe neighborhoods, that don't have pollutants, that have access to early childhood education, whose parents have stable health care, whose parents are doing well from a psychiatric standpoint, who have access to treat their own psychiatric problems, those kids are at less risk for developing all sorts of psychiatric problems, including anxiety disorders. And so I think preserving and making sure that children are living in a healthy environment, broadly construed over the first few years, is incredibly important.
And are more resilient if they do develop a disorder. They've got more resources to be able to address it. And I'll add one more point that you guys were making: access to the treatments that we know work, but also making sure that the providers are delivering them like they should be. Everybody says they do CBT now. And if you actually watch what they do, which I still watch tapes, then sometimes it's not really CBT. So not just saying, oh, yes, I do CBT, but asking, what precisely do you teach patients? What do you do? Do you leave your office with patients? Somebody who never leaves their office with a patient doesn't really do CBT.
I teach my students the exact thing. The majority of my patients who think they're getting CBT are not really getting CBT when we go through with them exactly what they're getting. And I think this raises maybe a contrasting perspective about access. It would be really great to get better access to the treatments that we have, but there's a reason why it hasn't worked. And so I think it's also worth thinking about, is it just because we haven't done a good enough job of educating people, or is it because people maybe don't want these treatments even though they work? And so it's worth considering, what is it about these treatments that people don't like as we think about how designing other ones?
What is it about certain treatments that people don't like? What is it that you've seen as falling short in terms of actually providing due care?
Typically, and I'm sure I would like Dan's opinion on this, a lot of parents resist medication. They worry that it changes the brain. Well, we do hope it changes the brain, but there's a great deal of public resentment to using medication, and I think we need to educate people. We don't, I mean, so far we have not found any long-term problems associated with early treatments, and I think it behooves us to help parents understand that.
So I want to make 2 points about this. One, and I'm sure you remember this story because it happened all the time. Again, this is 30 years ago. Rochelle and I would be seeing a child and a family together, and just like Rochelle is saying, the parent would say, "But doctor, isn't that a powerful psychotropic medication?" And do you remember what you would say? You don't remember. Rochelle would say, "I certainly hope so." Right? Yeah?
It sounds right.
Yeah, that's what Rochelle used to say. The second thing I'd say, I'm really glad Shan brings up the issue of autonomy, which it's really a good thing in terms of when we think about adults, that adults have the right, both because they can make medical legal decisions for themselves, but also because they're mature individuals. When they tell us, "I hear what you're saying, this is what I want," and we feel okay working with them, we don't have that luxury with kids. That as clinicians taking care of with kids, kind of like what Rochelle was just saying, we have a certain obligation of working with parents and recognizing that sometimes they need to be educated. And it's a big issue because you're absolutely right, and Shan's absolutely right, that some of the hard treatments people don't want and people don't like. And I do think it's different in adults when it's kind of easier because they're mature individuals who can speak from themselves and try to come up with a way to give them what they want. It's not so easy with kids because it isn't so easy of just doing what they want. And again, that's where you brought up the issue of funding. There's not only a crisis of funding in terms of clinical research, and I'm getting close to the kinds of issues I'm not allowed to talk about, so I'm going to be careful here, but in particular, clinical research with children and researchers who are studying mental disorders in children. And these kinds of unique issues, you really need people who work with children to tackle them in the sensitive way that yet acknowledges the problem, that we do need better treatments that are palatable, that people want. And we're far away from that in adults, but we're even farther in kids.
May I add that in working with parents, I think it's important if a child is a candidate for medication to emphasize that it's not a lifelong commitment, that they're essentially expressing an opinion, but it's not an informed one. And perhaps they should try. If they're not jumping off a cliff, they can change their mind anytime, and perhaps they can, and I think that helps them understand.
I'm surprised how many parents think that right after you've convinced them, so does he have to take it for the rest of their lives?
Exactly.
I still get that all the time.
Right. And you can help them understand that this is something that maybe they should consider, and the only way they can decide is to give it a chance.
The other thing I would add to this discussion, which I completely agree with, is, and again, this is stuff I learned from you guys, are that kids that have anxiety disorders relative to their peers are at increased risk for all sorts of things when they become adults, like depression, anxiety, but even bipolar disorder, substance use problems. So we know that growing up with a brain that's anxious has a lot of risks, right? And the evidence is that kids that get better, including on a medicine, their brains look more like kids that don't have anxiety disorders. And the kids that respond to medicine are not at some of those increased risks. So one thing I find helpful with parents is to flip it a little bit and say, the risks, yes, there are always risks. You might get a little bit of a stomach ache, a little bit of a headache, right? Some kids, they just get a few minor side effects. But there are known risks of living years with a mental health problem, such as anxiety. So it's not that you're only getting the risk of a medicine. You're getting the risk of a medicine versus the known risk of having a mental health problem.
Absolutely, that's absolutely correct.
Let's go back to the more novel area of psychedelics, and I'm wondering, Barbara, whether you think this too will be taboo in the same way that today it is about medicines and having to be forever? At what point do you think society will be able to, and eventually maybe even parents for their children, feel that this is something that they can dip their toe into? It won't be a forever element of life, or do you think it's a totally different type of treatment?
Well, it's a different paradigm. It's not to be chronically administered. The idea in the studies, the phase 3 studies with MDMA, they've given 3 doses. In our study, we're trying 1 dose, but it's not like, for example, the SSRIs that people take every day chronically. So it's a different paradigm. There's a lot of stigma about it. And I mean, I come into it saying I am a mainstream PTSD researcher. I'm not a psychedelic researcher, but I would feel crazy if I don't pay attention to the data. And it seems like there's something there. And I think that it's synergistic with the kinds of therapy that I do. It really, it's feeling in the room like the MDMA is giving them permission, giving their brain permission to go there, to go to the memories and access them and emotionally process them. So it might be a different paradigm that I'm thinking about, because I'm thinking the MDMA is helping us accomplish what we're trying to do with the therapy. It's not just about the medication. It really is a synergy. But, you know, there is a lot of stigma, but I think people hopefully will follow the data. So we're not so early, because some of these have been used for millennia, but we're early in the data that we like to see, and so I think it's still going to be developing.
Instead of stigma for you, Shan, it's about cost, I imagine, in many ways. And I'm wondering, you say when ultimately people come to you and they have their own autonomy and they want to make their own decision and go with you, they must be people who have ultimately the ability financially to do it as well. And I'm wondering whether you're seeing more support there, and whether it's a question of data for that as well.
Yeah, it is expensive. And the conversation that we have to have often for people who want to pay for this sort of treatment out of pocket is, again, we would often recommend that you try the cheaper things first, but that's a financial decision, and I'm a doctor, not a financial advisor. And so I try a lot not to give my patients financial advice. But that said, it's also worth thinking about the benefit also. CBT is also an expensive treatment. And if we get better at brain stimulation, we'll be able to make it cheaper. So if we can, the cost of life years lost due to the disability caused by anxiety, preventable life years lost, especially those that can happen in youth. If you can give somebody a stronger start, that I think I would imagine if somebody did the cost benefit analysis, it would pay for itself. Now, of course, that's the intent is to get payers to cover this sort of thing rather than forcing people to pay for this sort of thing out of pocket. We don't want, that's not a sustainable model at a larger scale, of course.
The justification of the costs is something that you sort of articulated a little bit, Chad, yourself, that, you know, the fact that you can treat with relatively cheap drugs from an early age and prevent terribly costly and psychologically damaging and inhibiting for the person going on in later life. How have you seen that justification articulated at a government level even?
Yeah, well, these are important considerations, and I think there is a question about like the societal costs, or who's ultimately paying these costs, versus the individual and what they can afford or not afford. And then, of course, there's what are the effective treatments that we have now, that we have a lot of data on, that we know are effective, like medicines and CBT. I mean, I'm a practicing child psychiatrist in St. Louis, and I sometimes have to work with patients to find even a medicine that they can afford, because the copay is higher for one than the other, and sometimes they have to shop from pharmacy to pharmacy to find like a pharmacy that will carry the specific drug that their insurance covers. So for a lot of individual families, it can be a challenge. So as the science improves for something like what Dr. Siddiqi is bringing up, it would be great for those families if those costs were covered by other payers.
I know Child Mind Institute does a lot of work in Greece, and they're looking at South Africa and other regions. I mean, Rochelle, from a global perspective, how is access, do you think, for some of the easily administered treatments?
You're talking about the United States or Greece?
I'm talking about globally. How does the US stack up, and where are we? Are you able to see that people have access more easily in other countries?
Well, we're not talking about essentially the economics of medical care, and that's an entirely different discussion. I deplore the system in this country where you have to depend on insurance to cover your costs, where they're not automatically part of your entitlement. I think we should all be able to get care when we need it without worrying about whether we can afford it or not. But that's a really political question, and one that is likely to be affected by the results of the next election, I'm afraid.
To the point of investment in more novel treatments, when we think of VR and way in which you're using that, Barbara, how have you managed to see the cost-benefit analysis, or at least seek it out and be able to ensure that this is something that's easily used and administered and accessible?
So we're talking about funding and studies, and I think that that's a wonderful way to give everyone who's available to participate in a study access to state-of-the-art treatment. But in real life, as Dr. Klein was saying, with our insurance and the state of that, and as Danny was saying, that the availability of evidence-based treatments, and then you put all of that together, if you want to add technology on top of it, then it just makes it even more complicated. But I think that that's some of the research that we can be doing, not just what works, but what we know works in different models for implementing it and getting out to the people who need it and in affordable ways. And I think that that's incumbent on us to try to help figure that out.
You know, the other thing, just to add to this discussion, is there sometimes can be a stigma for families to even talk about some of these financial considerations. So I've had patients where I've noticed that they weren't refilling their medicines as often as you would think, right? And I asked them, what's going on? Why, do you not like the medicine or their side effects? And what I find out in some cases, they're splitting the pills in half to extend it longer because the copays are so high. And so, just to add that, it can be an important consideration for some people.
These are the realities that many of our audience are trying to navigate. Can everyone just leave perhaps with one area of optimism that you have, or one thing we can walk away and actively do to empower either research and investment into new, more novel ways of treatments, or accessing the ones that are already ready available, or thinking about the ways in which these sorts of anxiety and disorders first begin? I mean, I turn to you down the line first and foremost. Shan, is there something that you're optimistic about in the way in which treatment is currently being given?
I think in psychiatric research, neuroscience is getting into psychiatry today faster than ever before. And I think that's going to help us with stigma. I think it'll help us with new treatments, and I think it'll help us with costs also. And so everything that I've talked about so far, like you said, is experimental. And the things that we've been hearing from Rochelle and Danny and Chad are about things that have been around for a long time. The experimental things that I'm talking about will hopefully, some of them will pan out. Probably some of them won't. Some of them will hopefully get cheaper. But the rate at which we're accelerating neuroscience getting into psychiatry, I think will change how we see this just in the next few years.
Barbara.
Treatment works. I want to give a message of hope. Anxiety sucks, but we do have good treatments for it. And even if the first one doesn't work, we've got good alternatives. Treatment does work for the majority of people.
Danny?
Yeah, I would just second what Barbara said, that we know a lot more about anxiety now than we did when I started, and particularly when Rochelle started. And we know that the overwhelming majority of kids with anxiety disorders get better and go on to live very fulfilling lives that are mostly free of anxiety.
Chad?
Yeah, I'll echo, in large part from work that was done on people on this panel. We have a number of very effective treatments for anxiety disorders. And so many patients that come into our clinics, we're able to get them feeling better. I'll also say that I think we are making a lot of progress in understanding the biological basis of anxiety disorders, including its early development, so that we can continue to develop mechanism-based treatments at least from the drug perspective, a lot of the current drugs that are used in psychiatry, including for anxiety, were sort of found by luck or by chance, not because we were trying to correct something in particular. But I think that we're really on the precipice of being able to understand a lot more and devise mechanism-based treatment. So I actually think it's a very exciting time for the field.
Michelle?
I agree. I agree with everything that's been said, and in that sense, I'm hopeful.
On that optimistic note, we want to thank you, everyone who is listening in to this wonderful roundtable. I'm greatly appreciative of all of our panelists' time, and we now are going to hand it over to Michael Miller for a little bit more.
Thank you all so much for attending this evening's presentations and discussion. I'd like to thank Drs. Klein, Pine, and Sylvester, as well as Dr. Koplowitz. I'd also like to thank our panel moderator, Caroline Hyde, and our panelists, Dr. Siddiqi and Dr. Rothbaum. It was an honor to have you with us tonight and a pleasure to listen to your powerful presentations and discussion. All of us at the Child Mind Institute would also like to once again express our deep gratitude for the late Sarah Gund, whose legacy will allow us to present a prize for research and mentorship in child mental health and facilitate conversations like this one we had this evening for years to come. I'd like to finish with a few takeaway points that came from the discussions and panel presentations today. First, I really think it's critical to underscore that anxiety disorders are common, treatable, and they're brain-based. One of the themes that we heard today is that they're rooted in the brain. And when we heard optimism about future treatments, the advances being made are being driven by neuroscience, by an increased understanding of the brain, increased understanding of how anxiety impacts brain function, vice versa, and about how to intervene. So there is great hope because neuroscience is advancing, and as the panel just highlighted, the opportunities for neuroscience to go from the lab to everyday realities are coming. With that said, there's also optimism when we look at ways of just improving treatments that we already know work, like psychotherapy. When we hear of thoughts like using virtual reality and other approaches for being able to either innovate existing psychotherapies or just to scale them, to take on one of the root problems that's been highlighted tonight, which is still, despite decades of advancement in research, challenges to access and care for so many. There are many paths forward that we can see from tonight's conversation and lots of reasons to be optimistic. At the same time, there are significant challenges that aren't just about the science, that aren't just about the healthcare system. They're more broad. There are many stakeholders, and I think that tonight's conversation really gave a multifaceted presentation that gave them many different aspects to think about as we try to move the field forward. And at the end of the day, really try to take care of what matters most, our children. I would like to thank you for attending tonight. And again, on behalf of the Child Mind Institute, thank you all for joining us for our 14th annual On the Shoulders of Giants Scientific Symposium. Have a great evening.